So the pleasure to have been given the opportunity to present a few evidences on the cavernosal regeneration, and I'm going to discuss beyond PRP here. So I would like to request the audience to stay with this. So it is going to be quite a long presentation, but I'm going to take you through the a lot of evidences. So this is what I'm going to discuss now. I'm going to discuss on the current management guidelines for ED, the position of regenerative or restorative therapies in the management of ED, and what is the knowledge gap in reversing the disease pathology, and what is the general course of the disease. And I'm going to tell you a few things about histopathological and the ultrastructural regeneration in the cavernosal tissues. And are the current investigations, are they helping us in assessing the degree of the cavernosal damage? And I'm going to give you an update on the pineal Doppler and guided biopsy. And I'm going to tell about regenerative therapies, the mechanism of action, the importance of patient selection, and the management protocol. So this is the current EAU guidelines where you can see they have mentioned as curable causes of ED, because we always know many times the ED is not curable, because the word curable means the patient is going to be a medication free for his having sustainable erection. So it's going to be a big challenge for us. And they are given all the possible solution as a first time, and it can be interchanged, starting with the intracavernosal injection of the vasodilative drugs, the vacuum device, PDE5 inhibitors, topical intraprocedural, intrathecal alprocedyl, and a shockwave therapy. And assess adequate use of chemotherapy only for the new things when all these things fail. So this is the fundamental thing we need to address here is, once we're going to once all the options have been voided, then they are promptly to shift to the restorative or regenerative medicine. So that is going to be a big challenge for researchers and for patients also. And let me show you some evidence based on that. And what is the position of PRP as a whole? This is from the EA guidelines, and they are still stating that the available evidence is insufficient because of lot of heterogeneity, and there is variation in the optimal application protocols, and we need to measure the growth factors. It is all true. And what they're expecting is that larger trials, and they conclude saying that PRP should be used only in case of clinical setting. This restricts a good therapeutic option being offered to the patients in a specialty centers, because we all know that in a non-specialty centers, people have been given this unscrupulously. Why I'm using the unscrupulously means because of poor patient selection, because of poor protocols, because of poor follow-up, people have this variable effect. But when it comes to the specialty centers, we need to optimize it. And always they wanted other trials. I want to emphasize here that regenerative medicine doesn't need a larger trial, because it's a different kind of study design, and we need to be pretty concise about the patient population. And when we see about this PRP recommendations, EA gives all these references, totally 9 references. I'll be going one by one. The first reference, they put this epiphenoma from the Russian study, where we can see only abstract, but it's a combo therapy. They have given a combination of low intensity shockwave therapy and with PRP. And again, the researchers, they concluded that treatment could be effective due to the anti-fibrotic effects. This is why I want to know that. Note it down. And they also know that larger study is required, still the trial is in progress. And because I couldn't read more about this because the abstract only available and it's all in Russian. So there is some restriction for me to get data. Then comes the next reference, what they quote is, this is not an article, this is a conference presentation from Dr. Dano. And what I understood from this, there is a confounding thing called a studio PRP. Studio PRP is a private body where it is run by an osteopathic practitioner, and plus it is done by 4 different researchers across Italy and US. I don't know how they collaborated for the work, and there is no study design. They just gave the results, and they have quoted, and the guidance have quoted this as a reference. Then came the reference from again the Russian study, where I couldn't see anything because the whole thing was not available for the public domain. And Again, the researchers who are given this guidance would have read only the abstract and they have included in the reference. Again, a next abstract from Dr. Russo, again the 34th Congress, where I'm not able to give the abstract, and this is again a combo therapy. The first one was combo therapy, the second one was only for PRP. This is from they didn't give how did they activate everything, they just gave the safe, viable, and said penal rehab, all are non-specific terminologies. And third came up autologous PRP, and they didn't give anything about the PRP activation at all. And fourth is again a combo therapy, where there is no data available. And fifth is something called as platelet-rich fibrin matrix, where the researchers they hypothesize that PRP can have a runoff in the periphery. So they want to make this PRP as a very solid gel-like thing, so that it can stay inside the corpora cavernosa. And again, it's a very retrospective study, and even though they have done for multiple urology indications, only 4 patients were done for the erectile dysfunction, and making very low power study. Then came again an abstract reference from the ESM Congress, and this is from the private clinic data, where they use something called True PRP. Again, it's a brand being promoted here, and the whole thing is saying that they have used a high quality PRP after training. Again, it's a highly non-specific thing to quote as a reference. These 3 are very good references. The first is Dr. Polios. It is a randomized control trial, double-blind placebo control, where the patient population was 60. Here, what they have noted in all the studies, the median age is cross 50, 55, see, median 58, 56, and the ED duration is cross 7 years, something even for 10 years. The main crux behind the regenerative medicine is to salvage a tissue before it goes for fibrosis. That is much earlier the disease pathology and much younger the patient also. Here the patient selection is again elderly patient, long duration. But this is a very good study because they have done a preclinical study, and they extended those preclinical study with the clinical study, and they have used an FDA approved separation system. And but main the inclusion the main IC is based on the MCID and IAEF. And here they are showing that intracavernosal PRP injection therapy, as outlined in the trial, appears to be safe and effective as a short-term therapy. And they again concluded as it can be an addition for urology armamentarian. And again, high quality is out to be warranted. Then came Dr. Shahar, again RCT, a placebo control trial, where the patient population was around 100. Again, mean age 56. And both the studies they took a multi-mode ED. And the first study they gave single injection, and second study they gave 3 injections, where it was 15 days apart. The first study was around 6 months follow-up. Again, the second study was around 6 months follow-up. Again, this also showed a good response. But then came the study of Dr. Masterson, and this is done in US, Miami. It's an RCT, double-blind placebo study. The population was 61. Again, 91 ED. They concluded that there is no difference between the PRP and placebo. So after the study, many again started to report the PRP is not working, but they all left the few evidences of previous one, but they started to report only this evidence again. So I'm just quoting this evidence for discussion. And these are all other things where Dr. Akodamuradi, he has shown that VEGF levels is low in case of pen with ED. This is one very good starting point for researchers, where we want to quantify the growth factors. So he had pinpoint on one growth factors among the multiple things. Then came a systematic review on the meta-analysis, Dr. Pathophysiology, where he did, so he was done basically comparing PRP placebo, PRP with the shocking therapy, and PRP with the shocking. So, but what happened here is only 3 trials were done for PRP with placebo. It is only PRP. Again, he also showed that saying this tendency. There was no so concrete evidence to show that PRP is beneficial. The study is favoring. So then we did a research, that is PRP of meta-analysis, and we took 4 trials, and we only focused PRP as a monotherapy. So we took the trial of Polios, Saher, Masterson, and Saleh, and we did a forest plot, a forest plot, and funnel plot, and the results were studied here. To start with, so we had first is IAEF score, baseline, 1 month, 3 month. As you can see from the baseline, the effect is slowly starting to shift towards PRP. You can see the diamond plot. The diamond here is going towards favoring the placebo, but favoring the PRP in the forest plot. And 6 months it shows that it is failing PRP. I'm not going to much in depth of the analysis here. Then comes the funnel plot. The funnel plot shows again high heterogeneity in the results. When we talk about MCID, it also shows, as I said, high favoring the effect towards PRP, both in the first month, second month, and then the 6 months. So overall, we concluded that even though the both a forest plot and funnel plot, sorry, the forest plot of IAF and the MCID, it is favoring PRP. Both funnel plots showed high variability. So this heterogeneity has to be controlled. The risk of bias also be tried, and every study shows low risk of bias, except for Saleh, there was some concern. And now coming to the question of stem cells. Stem cells, it has earned a very bad name if you research because of many common activities and many non-specialists who are entering this field and who are using stem cell very unscrupulously. And EA guidance, they quoted one meta-analysis, systemic review from Dr. Alokesh et al. And presenting the research of this study. So they made a meta-analysis based on this 5 researchers. 2 studies were using stem cells for post-radical prostatectomy, and 2 studies were using stem cells for diabetes, and one didn't have any. So one didn't do any basically etiology. ADRC means adipose tissue reverse stem cells, and PM means placental matrix-based mesenchymal stem cells. UC means umbilical cord MSCs, and BM means the bone marrow mononuclear cells derived MNCs. And again, you can always see here the average age has crossed 60. Beyond 60 years, a salvageable corpora cavernosa could be very minimal. So this could be one of the flaws which we are seeing while recruiting the patients. And the study was done for 12 months, 6 months, and I'm showing individual studies here. So ED with type 2 diabetes. Sorry. So this study was done in a medical school. This is done in Korea. The sample was 10. It's a randomized control trial where they took 3 controls and 7 participants. Mean is 70, and they failed to know tell about ED duration. And these patients, all the patients had failed medical management, and they were awaiting penile processes. This shows there were no functional corporal tissue, there will be minimal functioning corporal tissues during the initiation of this stem cell. And this is a 2010 study where those days many researchers were doing the called as penile root banding. They were tying the penile base so that the stem cells or the intended regenerative cells, they won't have any peripheral runoff. And they had a 11 months follow-up, and they have found a good improvement in the morning erection and a spontaneous erection. The rigidity was present, but these patients, they required either PD5 inhibitors or alprazolam for penile. But this is a very good sign. Imagine a patient going for penile processes, you are able to salvage the corporal tissue with a single injection, and these patients were again able to penetrate with medication, with surgery. And point worthy thing is, they're having increased glycemic control. This is there for all regenerative medicine study where once you give anything systemic, because once you give in the corpora cavernosa, this goes into the systemic circulation. So it goes for something called homing, which I explained later. So these cells, they see when whichever tissue is being damaged, they go there, they tend to exert their regenerative potential. So this may have gone to the pancreas, and this may have gone, this may have got some regeneration of the beta cells. Therefore, what they found out, there is improvement in the glucose parameters, in the blood sugar levels, HbA1c, and most importantly, there was reduction in the diabetic medication. This was observed between 4 to 7 months with a single injection. So at maximum of 9 months, 4 was erection and 2 required processes. But at the end of the treatment, at least 1 they maintained erection. This is for elderly patients. Imagine this can be attributed to the young patients, but no studies have been done till now. Again, a second good study, this has been done in the Jordan University. Why I'm quoting this was, we need to quote studies from medical universities so that there are strict criteria and we can trust the results, and not from any of the unscrupulous study centers. And this is called as a bone marrow aspirate study, where they aspirate the bone marrow from the iliac crest, and bone marrow mononuclear cells will be separated by densely gated centrifugation, and these cells will be kept in a flask. and these flasks will be given for some kind of processing, and the adherent cells will be given for culturing. And we use them as passages: first passage, second passage, and third passage. So this terms that once we use various flasks, and with the help of this second and third passages, and we'll be able to retrieve the cells, and these cells will be used for the patients. Beyond third passage, ideally patient minimum use, but some researchers, they tend to use till fifth passage. So they chose to give 2 intracameral injection on the bone marrow mononuclear cells. One they gave it the baseline, and one they gave it the therapy. They chose 4 sites, 2 on either sides, one in the proximal and one in the distal. The sample was 12. Again and again, the mean age is 55. It is beyond 50 years of age. Where again, the salvageable corporal tissue could be less, and the mean duration of diabetes is 12 years. And they didn't take note of the duration. This is very important, because patients with the duration of 1 year is not equal to the duration of 12 years, because disease pathology has progressed. And patients were advised not to take any PRP inhibitors. And they have found out that with the follow-up of 2 years, this is both safe and effective. All the patients, they had improvement in EHS, IAF, 15, and all its subcategories. So in both the studies, with type 2 diabetes, stem cells were showing a good predictable erection activities. Now coming to two studies of ED following radical prostatectomy. This is a study of Dr. Ha et al., where they use adipose-derived stem cells. This is done from Odense University, Denmark. This is basically a pilot study following efficacy. So it is basically a pilot study to prove the efficacy in patients who had ED post RP. So these patients, they didn't have ED prior to RP, and these patients have failed a conventional management, and they put them on 12 months follow-up. This is the adipose-derived stem cells. They were taken from the lipoaspirate from the abdomen, and after the processing, they were immediately given into the corpora cavernosa. And to prove that these cells were given correctly, they done a cell characterization after injection, because it will take more time. And this cell processing was done using an automated processing machine. And the total injection volume was 5 ml. And injection was given in 2 points. So injection was given in 2 points. Again, distal and the approximate. Used a tourniquet method in the base to prevent peripheral runoff. And out of this 21, 15 had they chose 15 had continence, rest didn't have continence. So I'm going to consider only this 15, because we want to take only the continence before erectile dysfunction. Out of those 15, 8 recovered, and out of the 8, 3 were able to have a parenteral intercourse without PDFA inhibitor. This is a noteworthy thing. Imagine for a post RP, where people tell only implant is solution. Out of 8 recovered patients, 3 didn't have any medications without any, they have erection. And out of the 5, 2 had PDFA, 2 had alprostadil. One was on penile rings, and one was on a vacuum device. And the adverse effect was due to the lipoaspiration. And what they was given was they took something called as stromal vascular fraction, uncultured cells, homologous cells, which is perfectly all right to give to the patients. Now this a second study, very good study, was done in France in a government institution. They again chose autologous bone marrow mononuclear cell based MSCs. Very good study design. They did a 2-stage design. Phase 1 followed by phase 2. In phase 1, they took 12 participants. They had a good study design that if the 12 participants didn't show any adverse effects, they will choose only next studies 6 participants. If there are some adverse effects, the phase 2 might have more participants. But here they choose only 6 participants because there are no adverse effects in phase 1 study. That is the stage 1 study. It's called as phase 1/2 study. They combine both phase 1 and this is what is called as regenerative medicine study. We don't want to go for a separate phase 1, phase 2. We can always come in phase 1 and phase 2 in a combined way. And again, I tell you, the mean age is beyond 60. The salvageable cavern is very less, and these patients have failed the conventional treatment, and they have put in on a 6 months follow-up. Zero improvement in both ages, no observable decline in the ED for in the erection for 1 year. Among these 12 patients in the stage 1, nobody was given. Nobody was they were given a processes because medication failed. No, 2 chose processes because 3 chose because they want to be without the burden of medications. It is their choice. But here they still had an age of 3 or 4. A point worth notation because these patients post RP they are deemed for processes, but here they are having a erection. And no technical difficulties because many times they say that it was fibrosis. No, absolutely no difficulties during the processes. It was a very healthy process insertion. One more thing, the last point, no evidence of prostate cancer recurrence for 5 years. This again I tell you because many say that stem cells when given for cancer patients can react. No, it will never do that. It can only happen possible only with the embryonic stem cells, not with these kind of MNs because embryonic stem cells are pluripotent stem cells. These are multipotent stem cells. They're lineage defined stem cells, so the cancer chance is negligible. And this is one study. This is done by a practitioner where they were not a good study design, open label, and they have given plasma matrix MSCs. This is has been given by a company where they have not characterized or quantified the stem cells. So again, but this study was quoted in the EAU references, and these researchers they told that no patients they require pineal processes after injection of this stem cell there. So how to fix this? How to fix the knowledge gap? So this was a pineal dissection, unfixed fresh cadaver, where you can imagine the sponginess of the corpora cavernosa. So it is our responsibility to go and salvage these tissues and as early as possible. This is a recent study where they have shown a drastic reduction in the collagen, in the smooth muscles when compared to the collagen in both diabetic and non-diabetic patients, just to show that the changes in the corpora cavernosa. This was published in 2022, and the alteration in the collagens also. So it is more towards the pro-fibrotic collagen, and they found out that 6 types of fibroblasts subclusters are inside the corpora cavernosa. So it is not only about endothelium. It is not only about smooth muscle. It is about the fibroblasts. These fibroblasts they determine the internal milieu. So we hypothesize that arteriogenic ED is a chronic, progressive, degenerative disease of corpora cavernosa, which includes smooth muscles, collagen fibers running inside the tubular albuginea, which forms the walls of those sinusoids and the sinusoid endothelial cells and fibroblasts. So this is again revisiting the old studies where this is a cadaver sample of young patient and an old patient. See, you can see the waviness, loss of waviness on in the collagen. So as age progresses, the collagen changes. Lot of changes happen in the corpora cavernosa. So that is when you plan for a research study, it is better to avoid an older population for a regenerative medicine research. And this again research, this is the first research hinting that need for a pineal biopsy in case of early disease patients, where they took many samples where they termed as a moderate to arterial insufficiency, and avoiding not only that fibrosis doesn't happen in these cases only in case of a prior person. So still, whatever we deem as an ED, where a moderate or severe, there are salvageable cavernosa tissues which has not gone for fibrosis, and these are all the changes which I'm going to go in depth. So we can see there are multiple changes in the mitochondria, in the basement membrane, in the capillaries, in the connective tissues. So anyway, just to show that what are changes can happen, say there can be a smooth muscle changes, there can be an fibroconnective tissue changes, that can be changes in the endothelium restriction, so that can be changes in the mitochondria or the basement membrane. So these all have been proved earlier. So morphological alteration of the cavernosa alteration in patients with the arteriogenic ED affects primarily the smooth muscles. Then came So again, as second research, 1990, reiterating the need for early detection of the corporal tissue degeneration by a biopsy. And these samples, they are taken from normal samples from the 3 brain dead patients and remaining from the ED patients prior to implant, where they have again proven that altered cells are increased in case of ED patients and normal cells count as decreased in ED. It's very old research, but still those researchers, they are trying to prove that cellular pathology is a crux here. Again, they're showing that early detection is very important. I'm going to skip this slide and this also. Then came the era of automated biopsies. This is a very game-changing article where SPs had proven that the biopsy, the pineal biopsy from a ED patients or a normal patient, as an outpatient procedure using a lidocaine, is very safe and there is no hematoma. And what I found is that a single biopsy can represent the whole the tissue because it is a homogeneous degeneration. Then Dr. Goldstein came and he again fine-tuned the procedure by giving which gauge needle has to be used, and sample of tissues has to be carried during the pineal procedure because it is just to make sure we're going to be comfortable in the pineal biopsy procedures. Again, a demonstration of the procedure where with the local lidocaine, with the biopsy gun, clinical gun, we can always sample to the ballono-preputial groove. Absolutely safe, no bleeding, no hematoma even in a single patient, even on a long-term follow-up. So it is safe. This has to be as a routine follow-up. So it's a routine workup in case of ED patients. Management decision, particularly prior to implant surgery, because this is a very good article where they're showing that before doing implant surgery, assess their fibrosis. That don't go implant surgery. Very good article. Then came a morphometric analysis of the tissues. Beautifully done pathological study using an automated system where they took the biopsy gun, they sampled it, they found out the amount of functional tissues and amount of the fibrous tissues. And they compared even with the manual accounting, and they found out that in patients with ED, the fibrous tissues increase is more. And they're given a score also. So we can have when the patient is not responding to medications, before going to implant, with the error of this AI, we can, if we go to an analysis of the cells, we can decide whether the patients still have salvageable tissues before going for the regenerative therapy procedures. Again, they told that they put it like it is easy, it is safe, and it is not so without any complications. So whether to say be happy or not, the error of accelerator came in, and we had a very quick fix solution for ED. Accelerator conditions came. So in this process, we forgot to evaluate, and we moved on to the habit of giving end-stage solutions. The patients are not responding to medications. So, are the current investigations are helping us to assessing degree of the damage? This is the recent pineal doctor done by Dr. Sarazo. Beautiful done by him. I have not seen anyone doing anywhere in the places where I have visited, where there's a routine trend to see only the peak physical velocity and EDV, and they tell 0, 5, 10, 20 with the AV stimulation. He assesses the degree of fibrosis by measuring the cavernosal wall thickness. This is a sample image, and see this result. This report, beautifully given report. This gives an idea of what is happening inside, what is the grade of fibrosis, and what is the blood flow. I'm just giving us a consolidated image. I'm not quoting any of PSC or EDV. This gives an idea that whether can we have a salvageable tissue, whether we go for a PRP or stem cell, or we can directly go for implant. Still, this patient is a 30-year-old patient, non-smoker, non-alcoholic, not known case of diabetes or hypertension, non-obese, physically active. Only thing what I'm seeing is stress, and he sits in this. He sits on the desk for a long time. It is called as sitting disease. It is proven that if the person who sits in desk for 6 to 8 hours per day, even if he doesn't smoke, it is equal to smoking a pack of cigarettes. So this is called, this can increase the chance of fibrosis also. It's a different kind of discussion. So penile Doppler done in this way can replace need of biopsy at least. This is again a research done by Rahim, where they have found out that a simple grayscale ultrasonography can give us lot of information in the functional cavernosal tissues. These can give us an idea that whether we go for a implant or for a PRP or for a stem cells. Again, a new things coming up, shear wave elastography, but when it was spoke Dr. Saraswati, he told shear wave is not a way for penile. We have to strain wave elastography because the compressibility of the vessel wall is less because the liquid in there. Again, let's say discussion. And it's all for researchers where we can show that myogenic degeneration can happen irrespective of good artery flow. This can be one of the indications where we can give stem cells for patients even though he's having a good PSV or EDV without any fibrosis. And so these factors can be from the external source. We can tell we can give active HF, but nature has given that there are factors which we don't know also. That is why we should give cells, because these cells they give factors which you know and which you don't know. That is, it can be platelets, it can be stem cells, or it can be exosomes. Exosomes are the growth factors which are derived from the cultured cells. So once we culture the cells, we take on the cells and we take only factors from them. So this all you know what is PRP. So it has, I'm going to skip it. PRP in platelet, it has alpha granules. These granules are the storehouse of all the factors. So our aim is to how to break those alpha granules to release all those factors. Then comes the activation. So in the process of activation, we tend to get all these factors. VEGF is also called as angionurin because it is going to produce arteriogenesis as well as neurogenesis. So we have multiple active protocols. In India, in my center, we follow the call as freeze protocol because we found that freeze thawing gives much more higher amount of factors, growth factors in the PRP. So it's called as platelet lysate when we do using this active protocol, freeze thawing method. And various factors, various mechanisms for analysis and so why there is variability in the efficacy of PRP? One, there is lack of PRP standardization. Many have dilemma whether we can activate internally or externally. So what is internal activation? Many assume that once we give this platelet plasma, platelets they go internally and they burst open factors. Many times we don't know how much intensive or how much efficacious could this internal activation be. And again, as I told, lack of the factors quantification, no follow-up, poor patient treatment because we always tend to empty all the all the drugs, everything is working, then we tend to think of PRP. No, if the patient diagnosed with artery dysfunction, when the patient is responding to this medication, it is high time we can give this PRP. Again, mechanism of PRP, it can help in angiogenesis, collagen regeneration, nerve regeneration, and spool integrity. So it's all known things for us. Very easy. It's an office procedure. We can have two spins here. Simple centrifuge. We don't require a very sophisticated system here. Simple centrifuge with a sterile tube. We can prepare PRP. We just have to take PRP and we have to give to the patient. Very simple and very effective method. It is all approved thing. And PRP is an autologous thing. It is patient own cells. So there is less issue of safety. And there is absolutely no issue of any regulatory issues because it is patient own cells. It is minimally manipulated. Then comes stem cells. Depending upon the surgeon's preference, they will take if the surgical team is with an orthopedician, they take bone marrow. If they are plastic surgeon, they take adipose tissues. If they are dentists, they take dental pulp. If they are non-surgeons, they tend to take from the umbilical cord tissues or the water jelly. And these MSCs, they can be given allogenically. That is, other cells can be given to others because it is immunoprivileged. There is no MSC, so therefore no matching is required. It is completely safe. It also has immunomodulatory action, and it can be easily extracted from the adipose tissues, bone marrow, dental pulp, and yes, once you give some growth stimulating factors in the blood, after 2 days, 3 days, you can always withdraw the blood and you can separate the MSCs. You don't have any of the extraction techniques. How do these cells act? It's called homing. These cells, they sense where there's a damage. These cells, they sense the crying into the body. They go there. They produce mechanism in 3 pathways. One is transdifferentiation, pathway activities, and cell fusion. What is transfusion? The cells go there, they transform into the damaged cells. It's called as plasticity. Then what about paracrine? They go there, they sense what are required for the area, they tend to secrete all those factors and the cytokines. Then comes the cell fusion. They go there, they fuse this with the cells, and then we exchange the damaged thing. Because I've shown you there is damage of mitochondria, damage of basal membrane. So these stem cells, they tend to come organal transfer. So by these mechanisms, stem cells act. And this was the ultimate mechanism, that is final thing, where they have this abrogation of this anosynthase, where there is a reduction in the fibrosis, there is angiogenesis, immunogenesis, all the factors being released, and these are the concise mechanism of stem cells. This is how this is a picture from a place, an articulation of Ravi after he's aspirating the bone marrow, and this is a device where we can separate sterile bone marrow molecular cells in a closed system. This is called as SEPAX, where we give the bone marrow aspirate, it separates and gives a molecular cell concentrate here, ready to use for any indications. Safe and sterile. If you want to stop here, you can stop here and give patient. But if you have the culturing facility, if you have a GED facility, you can always go for culturing. So from the bone aspirate, you can go into a flask, and this flask can be used for passage 1, passage 2. You can expand this bone marrow to give bone marrow mononuclear stem, sorry, a bone marrow mesenchymal stem cells. This is how a passage 3, 4 stem cell appears in the flask under microscope. Spindle-shaped cells with a confluence. Now coming to the shockwave, because regional therapies cannot be without shockwave therapy, because shockwave therapy is one of the easiest office-based procedures. And again, EA told that data is insufficient, and there are multiple data. But what is happening in the shockwave therapy? Yes, sir. Thanks so much. Thank you so much. Few statements. So we have shockwave therapy given for mild to moderate groups, and many have shown non-responders to be inhibitors. And there's always a discrepancy between radial or focused, or radial or focused or unfocused. And we also had data on long-term efficacy also. So sufficient evidence are there. We have multiple systematic review and meta-analysis, but still the field stated that shockwave therapy lacks validated data to give an evidence-based approach. So mechanism of shockwave therapy, release of the factors. Main thing is this is one, the mobilization of the stem cells of the associated cells. A new research going on in Miami again. It was a cocktail regimen where they combine both shockwave therapy and PRP injection therapy. So to conclude, in India we have 6 Indian FDA DCG approved indications using stem cells, and few are in phase 2 and 3 awaiting further approval. And in all of those indications, tissue sampling was done to prove the regeneration was with reversal of fibrosis. With ED, the evidence generation of cavernous regeneration is presently completely modest. It happens in humans to be apprehension in the biopsy by these specialists. Urologist should attempt to sample biopsies in perineal processes patients prior to cavernotomy or corporal aeration. Regional andrology collaborative network should be started to pool research data and to collaborate large-scale studies for evidence generation. Regional therapies should not be considered as an proactive medicines. It should always be considered as an adjunct therapy to a standard of care, and should be offered to patients at the earliest time possible after the diagnosis of ED is made to avoid ongoing cavernosal degeneration. Treatment aims to increase sexual longevity with spontaneous natural erections and implants, or be considered a last resort with perineal biopsy or ultrasonogram showing extensive cavernosal fibrosis. So ultimate satisfaction should be the couple. It should not be the only with the erection thing, because you always see post implant the wife is so happy with the way the partner is handling the processes, or the way she's feeling the processes inside her. So before choosing a therapy as end-stage therapy, please ask yourself: will you do it for yourself? Will you do it for a son or son-in-law or for a father? So this will give us an idea whether we should go for an end-stage procedure or we can choose any regenerative therapies. So to conclude, regenerative medicine or cellular pharmacology is a present therapy, not future. It is in a conventional therapy. It's always a substitution or a symptomatic therapy, but in case of cellular pharmacology, we have to regenerate and reverse the disease process. So I always want to pay tribute to my mentor, Dr. Chandranayan sir. This is our team where we have done the world's first MSc is for the osteoarthritis grade 2. Those couple of years back. Thank you for being kind enough to listen patiently.
Thank you. Thank you so much. Nicely, very nice presentation. Actually, we surgeons don't think about these regenerative medicine.
Pardon?
We surgeons don't think about the regenerative
usually
medicine. Yeah, we jump on the benign processes.
Same thing happened with the occupation. So they
Well, it does depend. So I think it does depend in which moment. I mean, because one of the studies you presented, they started with the generating medicine after 6 years.
Yeah.
I
Yes.
think that makes
It
not
should be
really
in the
sense.
beginning. It should be in the
Exactly,
beginning.
that's what I mean.
every research
Yeah.
is
But the data are not that good.
not good.
No, they are not that good.
Data is not good. Patient is not good. That is why this therapy is not progressing.
No, that's what I mean. But
See, because
which program or which protocol would you recommend?
Okay,
Before
my
the
protocol,
process,
which-
before the
how we are doing that, okay. Assess something called as arterial stiffness, something called as
Sorry?
arterial stiffness,
Stiffness.
pulse wave velocity.
Okay.
It gives an idea of how stiff the artery is, that's number one. So we can tell that the degree of endothelial dysfunction in that. This is proven data. We can have multiple data, a central stiffness, a current femoral, a pulse velocity. We have a Spitmo, we have Genesis device, many things are there. Second is something called as a vascular reactivity index, where a device called as, you can use EndoPAT or Wendy's, where they tend to tell the endothelial nitric oxide levels,
But
how much it is given. Yeah, how much percent.
so what are you trying to prove that you, so because you want to take biopsies,
No,
right?
see, a biopsy or the USC will be the ultimate, because to show there is a regeneration, there is regeneration, we should do this. Once you show the regeneration, then you can always postpone the implant. It is not to avoid implant, it should postpone.
I know what you mean. The problem is still we really have, because so what we do in our, so I mean, I don't work here in Spain, but in Austria or here in Spain, you cannot use it unless it's in the context of a study. So you cannot use it just because. So you need a study, you need an ethic committee, and you need a study.
So why don't we do a research study here? We can have a very, like.
Exactly, but that's what I mean. What do you, or in which group of patients do
okay.
you want to prove
Young
it?
patients.
And how do you want to prove it?
Young patients, early onset TD, who are still responding to medications.
Okay, and
You-
how?
You opt them that Dr. Saraso is doing ultrasound Doppler, no?
Mhm,
He shows fibrosis now.
mhm.
And
Well, he shows fibrosis, but there is no categories of fibrosis.
No.
It's something, there is no categories of
he's
fibrosis.
given, grade 3, grade 2 is given
But
that.
he's giving it, but it's like if I give another, so it's not something that it really, there is no classification at all.
That is
It's something
because,
he's
yeah, that
doing
is
that.
because ultrasound has to be done by KD physician. Those days.
Okay, so
20
you
years
want
back.
to use a classification.
At least there is fibrosis, no? You can proceed with that. If there is fibrosis, you will regenerate, so you want to regenerate. Our main aim is to
It's
regenerate.
not easier
But
if
Father-
you're asking the patients with a questionnaire, if
See.
they're getting better or not. But the other thing is when you inject PRP or plasma or stem cells or whatever, even if you do a tourniquet, but even if you're doing a tourniquet, the cells are moving. I mean, you're not keeping it in the penis because the flow
No.
is all the time.
True. See, that is why the method of PRP is more significant. When you, when you completely lyse it, you break over that, it becomes so sticky. The preparation freeze thawing method, which we observe, we get a sticky PRP, it's called platelet lysate.
Okay,
So it may stay there for a long time.
okay.
So when we tried with the calcium chloride, the effect was not significant.
And how can you make the PP is for every patient equal or more or less the same?
So what we done is, we did a study for measuring the VGF levels, VGF, TGF, IGF, everything. And we have found out that this much amount of platelets is required for us to prepare this much amount of factors in this patient. We have standardized it. Now we take the like a PRP, we activate it. So now we know that per ml of PRP, we have these many amount of factors.
But what I mean is every patient has a different amount of platelets, right?
Correct, but once we go to standardize it, no?
You?
Once we standardize it, a time of platelet, see, once we standardize the method of PRP preparation, we take the platelets, how much amount of platelets is required prior to activation, everything when we standardize it, then you have a prefixed amount of growth factors in your PRP.
Okay, so you take blood.
I take blood, we count number of platelets, and we call it a freeze thawing.
A freeze?
Freeze thawing. You freeze the platelets and you thaw it. Repeat it cycles.
Freeze and thaw.
Freeze and thaw.
Yeah.
Either you freeze it by keeping in the liquid nitrogen,
Yeah.
then you thaw it. Either you take it off or put it in a room temperature water.
And what about, there is a machine, I don't know if you know the one from Atrex, they have like a double syringe.
Yes,
So
that is a routine method of PRP preparation. It's called PRP. It is called as platelet plasma. What I'm saying is, you break open all the platelets. There are no platelets at all. In the heart, there are still platelets over there.
but you need platelets.
We break open. You need growth factors, right? You need platelets.
Okay.
So we quantify the amount of factors in that. You take platelets, X amount of platelets can be X amount of factors.
Okay, so you're not using the PRP, so you're using
Platelet
the,
lysate, yes, we're using platelet lysate.
you're
This
using
is
the
next level
growth
of PRP.
factors.
Yes. Very simple. You do that, then you capture the platelets. Patient has to accept, because patient might accept, because you tell them that this is an ongoing disease. You may respond to 5 mg medication now, later 10 mg, 20 mg, then eventually processes. So how to do tell patients, these therapies can halt the disease progression. You can stop this progression. It can reverse the disease process, and it can make them to respond to low dose medications.
And what about sponsoring? How easy is to get a sponsoring about it, because no one is commercializing?
Yeah, true. Okay. There are no sponsoring societies here.
Sorry?
There are no sponsoring societies. We can apply for grants from some societies. We can ask them. See, that is why I have prompted this one. You see this Regeneration Andrology Collaborative Network. We have multiple study groups all over the country, right? All over the world. For this, we have a network where we can exchange data. We can have share data. We can always tell them we can sponsor this one, this one. Always.
How long does it take? I mean, so the patient comes, you take blood. Because you take a normal blood test.
Yeah, not good, yeah. Blood.
So you've got it in 1.5 hours, let's say that.
Yeah,
That's normal 10 ml blood you take.
Sorry?
10 ml blood, 10 ml.
10 ml blood.
10 ml blood you
I
take.
don't know what that's in.
10 ml blood.
Yeah, but you take no, but what I mean is you do a blood test, or you do you take blood.
First instance, we do a blood test to see the number of platelets.
Okay, that's what I mean. So
if the platelets are low,
takes-
150, I mean half patient, some person they have a less number of platelets. Not up
No,
to
we
the
should
mark.
see why that. If the number is so significantly low, then it is management. The LC is within a normal range.
What is the, I mean, the criteria, lowest criteria you have? I mean, for example, the normal criteria is 3 lakhs, for example. So what is the minimum criteria?
See, I can't tell you just like that.
Yeah.
One is the time of aspirate the blood testing.
Okay.
The time it is, because we observed that morning time you take, there is some variability. Afternoon and night. So it depends upon the country also. Here you need to sanitize it. And you need to sanitize it. How much amount of when you activate
No,
it?
but what I mean is how, because at least for me,
Well, yeah.
I don't know here in Lyx, But for me, it's really difficult if I have to make the patient come like 3 times. So I need to be really efficient.
Why 3 times? 1 time is enough, no?
I don't know. So I'm asking you, how long does it take? So I take blood.
You take blood, you must have so all the counts over there. Then immediately go for active protocol. Your PL is ready. Patient will be posted on the day. Morning you take the blood count. Afternoon is ready. Then you procedure. All day care.
So the whole day.
Yeah, day care.
Okay, no, I don't have the whole day. That's what I mean.
No,
So
no.
okay, but
You will have to do that. We have a team of biotechnologists. They do for us. We have a regeneration team, no? This will be a lab person. They know how to activate it. We don't do that.
But there's something I don't understand. So you take blood.
Yeah.
You make the account of platelets in every patient.
Yes.
Then you centrifugate, you activate. How do you activate
Centrifugate
it?
it and activate it.
But how do you activate it? So I need you that you tell me everything.
Yeah. You have liquid nitrogen, no? Liquid nitrogen is there.
Liquid?
Liquid nitrogen,
Okay.
where you store all those.
Okay, no, okay.
So you dip the PRP which you prepare by certification into
Okay.
that. It's called freezing.
Okay.
Then you thaw it.
Okay.
You take it out, either keep it room temperature or put in the warm water.
Okay.
Warm water. You do it repeatedly.
A what?
You do it for repeated cycles repeatedly.
Okay.
This is given in the articles.
But that's something you're doing manually, or it's something that it's
Manually, it's a manual thing.
Okay.
You do that. Once you do that, it is all
so
given.
you have to explain that to me as if I'm
Okay.
silly.
Okay.
Okay. So I don't
So
understand.
this is completely very manual thing. You don't even want to have an artex also. Yes, a simple centrifuge.
And how long? Because it does depend on how long you centrifuge and which speed.
That is what that you need a standard with the lab. Lab standard is required. How much a first pill is required, how much a second pill is required.
But that's what I mean. It does depend.
We need to see in your lab here.
In your lab, yeah.
In here, we need to do that. I can give one article what we're doing there. I'll give numbers, how many RPMs, I'll give that. Based on that, you tell your lab person to do that. It requires some 4 or 5 days of thing, some calibration. Then you do that.
The thing is, we have to do it the same. So it makes no sense that I do something in Austria, they do something here in Lyx, and it's not the same. That's what I mean, because that's the problem with all the studies. They're doing, some of them are doing 5 minutes, some of them are doing 10 minutes, some of them are doing
If ultimately do that and you take the factors from it is not about the PRP. You take it and you prepare the PRP and you do freeze thawing. That freeze thawing cycle might vary. We do for 2-3 cycles of freeze thawing.
How long you will take? I mean, for freezing, how long you put in 2-3 minutes?
2-3 minutes, that's it.
Okay.
We do that, then we had done it previously. See, like why am I doing 2-3 minutes? Previously we done for 1 minute, 2 minutes, 3 minutes, 5 minutes, 10 minutes. No, it's okay. For 2-3 minutes, it's fine. Because in this frequent timings, we are able to break open all the platelets.
So this freeze and thaw cycle break the platelets.
Is done by by lab technician.
No, but this freeze and thaw cycle break the platelets.
Yes. This method is called as platelet lysate preparation. Your break open platelets, then all the factors they come into your preparation. You give only that. It is more sticky. It won't run off. With this method of activation and preparation, we are seeing good results. With the orthodox PRP, not much results.
Okay.
How long you keep it in the venous? Injection, yeah.
We choose 3 sites. One in one near the corner sulcus, one in the mid shaft, and one in the base.
If you put on 3 sites, then it can cause corporal fibrosis.
No, nothing. One injection only, small needle.
Yeah.
Small needle.
But there is a connection between both corporals. I mean, if you put the blood from one side, it will go automatically to the other side.
True, but ours is sticky,
Okay.
It's sticky. So it is not like everywhere it is a connection.
Hello.
Hi.
Hello.
Hola.
Hola.
Es lo mío, ¿no? Estaba mirando
Sí.
los ordenadores.
Puede ser que sea tuyo.
Hasta luego.
So for you to start as a research, and it is, I don't know about the system here, that there is no need of an approved FDA system and all. A routine safe centrifuge can be helping us. Simple centrifuge, you can spin it off, withdraw the upper layer, then respin, take PRP, dip into the regeneration, freeze thaw it, and you give that. I'll give proper protocol. Now, your job is to select which patient is required for patient. Whether he requires X dose each year, because we used to give, we have taken note that 5x, 6x, 7x, 8x, because we have something of an surrogate assessment of pulse wave velocity. If it is more, that means is more amount of artery involvement is there. If it is vascular activity high, index high, that is more amount of endothelial dissection is there. So we all have a surrogate markers. With you, with the expert center here, you can do with pineal Doppler or take biopsy. At least for 10 patients, in implant patients, with the biopsy, you samples.
But what do you mean with the implant patients?
Anyway, you're going to scoop off these all the tissues, no? It is safe.
Yes. But
Why
why
is
do
it
you
implant?
want us to use the activation?
Biopsy, because you need to be confident in the biopsy.
Yes, but so when are we administrating the activation, the factors?
No. This is only the implant patient. Just for you to make easy with the procedure, just do biopsy.
And what are we doing with the biopsy tissue?
Just self-analysis and see how much is. That's it. You need not even check for analysis. It is just for you to understand how to go through the build-up preparation group, take the sample, and send for analysis. That's it. If this is done safely for 10 patients without any issues, injury, hematoma, then you will be confident to do for non-implant patients now. Because all things are proven there, no?
But how do
if
you?
you breach the penis by putting the trooper biopsy,
See,
needle
that is why I am showing all this, all the data.
no,
No,
but this is the dangerous.
why dangerous?
Invasive procedures.
Why
I mean, if the patient is having a partial ED and you are
And you're
putting-
biopsying?
you are doing biopsy and putting the trooper needle.
I have shown you 3 articles, 4 articles showing biopsy is safe. 4 good articles.
No, but
No.
because in hematoma, it can cause
No hematoma is
venous
there.
leak. What is it?
Can you put again the?
Yes, I can show you.
Can you put?
This is not open biopsies. Open.
Yes, but
Open
how many
sample
patients?
implants.
Wait a second.
This is the first study of approach biopsy. This month.
Which,
No, wait.
so first of all, which year?
This is a 1990.
Yeah,
Okay,
too old.
30 years, okay, can you put how many patients? 5 patients.
Five
If-
only.
if-
No, this is first study. This is the first study.
This is what?
First study, very first study where somebody has done for a.
Yeah, but that's 5 patients.
No, I will show.
Okay, next one.
They are taking from the 2-3
So balloon preparation group.
biopsy needle.
So you can forget that I do that, but
What
can
type
you
of-
put the other study?
This study. Out of 5, none should have.
But that's 5 patients in 5.
Okay, can you give me an ideal number? How many patients would be comfortable for you to understand that is safe?
30 at least.
30.
And they have not
10
mentioned in the
patients.
material method the size of the needle.
No, it is given here.
Given it.
It is given
Efficacy of 10 impotent men, okay, 10 patients, okay,
Given gold chain.
yeah. Okay,
Okay. This is methodology.
Then 19 gauge needle.
Yeah.
okay, so can you?
10.
Next slide.
Patients, okay,
10 patients, right? Next slide.
yeah, yes. Next one,
Painless, safe. Okay.
yeah, but it's,
Next slide, please. Yeah.
33, okay, so then.
So now your your count has come now.
That's, 2,
3rd the ED and 2 normal patients. Normal patient.
nine, 10.
I can give the article now.
Yeah, that's good. One having a significant difference when found patient and 60 high. Okay, do you have more information about
Yes,
this
I have.
article?
Yes, yes. It's how they do this analysis and all.
Yeah, blah, 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 to compare patients. Okay.
Next slide.
Excellent.
How is the analysis and all? Okay.
Excellent. Okay.
Will change?
Well, if you need more time, just tell me. We believe safe representative. No significant. Nevertheless, to avoid possible but they don't say anything about the complicate without any major complication.
Yeah, they're given there. Maybe I skip it. See. It is
I really want to see the
I'll show-
article. I
I'll
mean,
give you
it's
the article itself.
25 years old, but
I'll give you
anyway.
the article.
Okay, yeah, that's good.
See, this is what the last thing you should see that. All the precaution, if the yield is valuable, then you change it.
So I think it's going to be easier in patients undergoing a surgery, of course,
Because it is safe for you to practice.
but. And is there any other study in the last 10 years or something?
Because
like
all Viagra came, no, they know who's going to biopsy now. That's why I told you, with the era of this sildenafil, the need for search for degeneration is went off because it's all a pharmacy based, no? Big pharma, only a big pharma can do large scale studies, or a group of network researchers can do large scale studies.
Okay.
That's why I'm proposing that we should form a network where we can do large scale regional studies. Else it is not more possible. All these drugs only will come.
Okay.
So prior to biopsy, you do this what do you, like a USG, then you know where to click on all. It is like an what is called as.
And then with this tissue, so that could be only so that it's only to assess the fibrosis degree, right?
Yes.
And you want to correlate that with the images from Cerezo.
Because once you are so sure with the procedure of the biopsy, you can do pre-PRP or pre-stem cells and post-stem injection biopsy.
No, or once you can correlate with the ultrasound and the biopsy, then you can correlate the PRP before and after.
Exactly, that is my idea only. Then we can tell this is sure. See, this is a game changer thing for patients. For surgeons, see, you again have an extra thing for patients. You think like that. Don't try to put everyone on the implant things.
No, not really. I'm not putting everyone
not
on
you.
the implant.
I'm saying in general for surgeon.
But-
We put implant when there's a complete fibrosis, most of the time.
That's the thing.
Then the sildenafil not.
People non-consummation who are able to masturbate, but they put them on implant.
No, but that's probably in India. That's not my
Non-consummation is a.
So we have to really have.
It's nothing to do with the PRP and this.
I will show articles proving that a penile implant is a good thing for non-consummation. The article from an Indian.
Penile implant is a.
Good option for a non-consummation marriage.
Yeah, it's definitely, I agree with him.
Where is fibrosis in that?
Yeah, no, but if the person cannot do anything for a long time, even the psychosexual therapy is not going to work, then definitely the implant is the ultimate.
Yeah, but that's only a minimum percent.
Minimum,
That's
very-
a minimum
yeah.
percent.
Maybe-
But there are patients who are
Exactly.
undergoing.
See,
Not
I-
every patient.
My concern
But normally-
is, this is one of the options
Yeah.
where we should not neglect to the patient.
No, that's what I mean. So we normally have to prove that no other medicaments or drugs are helping the patient, and that they really have a problem, a
No,
vascular
no.
problem.
Before the medical evidence failed, this has to be given.
No, what I mean is because before the prosthesis, that's what I mean.
Because this is process again a degenerative.
No, I know. So you have to have at least a little bit of the mechanism still there, yeah.
No.
Yeah, true, a functional issue is still there, yeah.
Okay,
But it's a good thing. It's a good thing.
So what
Regenerative
is the next
medicine is a
somebody
good
is
thing.
interested? Can we try this to
Your
impact patients?
presentation has opened our eyes, you know.
I'm
Yeah,
not
we should
here
think
anymore,
about this
so
also, yeah.
I'm leaving next week or this week actually, so.
You don't have any problem with the patient. See, we are actually trying the cadaveric care. See this, try this. This is a ball biopsy gun, which I tried.
You can convince Juan Ignacio.
This is a biopsy gun, which I purchased and we did for the implant. For the cadaver. But we didn't go because we are fixed cadaver, no? Didn't go well. We tried, I tried to make it extra. I tried to some people. But it's all in the judge's hand. Can stop the recording also.
Yeah. Please close it also.
Well, the Yuan is still